Thank you very much for your kind words. I'm sure I do not merit that. I would also like to thank the organizers of this conference who invite me to talk. So the talk will be a change of gear from what you heard this morning. It will be on the thrombotic complications in hematologic malignancies. And to start with, I would have no conflict of interest to declare. I would like to cover a different aspect of the thrombosis in hematologic malignancies by discussing the incidence of that, a little bit of the pathophysiology, and I would like to use these 4 different diseases to illustrate the problem. And wherever it's appropriate, I'll talk a little bit about the management. So on the incidence, it's been found in a fairly big survey a few years back that while the incidence rate for thrombosis in all cancers is like 1.3, and the 3 most notable thrombogenic type of solid tumors like renal cell, ovarian, and pancreatic carcinomas, it's 2.5. And it is a little bit surprising at the time to know that in these 2 hematologic malignant diseases, AML and non-Hodgkin's lymphoma, the incidence is pretty high. And these are on incidence 1 year prior to the time of diagnosis of the cancer. And this trend persists during the chemotherapy of the patient. So the incidence of thrombosis is 6 to 8 for all cancers, and for hematologic malignancy, it's high. So it is because of this, there's a lot of attention paid to the thrombotic complications in hematologic malignancies that previously did not receive too much attention. So if we look into the pathophysiology, how the classic Vieux-Carre's triad applies to the hematologic malignancies, we can look at the present-day concept for his first of the triad, the abnormal blood flow. So it applies to the hematologic cancers. You can see that some may have hyperviscosity from these different factors. And as far as the abnormal blood vessels, the second of his triad, there is the tumor invasion of the vessel, but more importantly, with the angiogenic switch of the vessels in the tumor, the pathologic angiogenic vascular tumors, particularly in the microvascular tumors, shows a very, very abnormal picture. And obviously, we should also know that wherever there's cytokines, either pro-inflammatory or pro-angiogenic cytokines, they upregulate which I'll talk a little bit later, tissue factor expression, and therefore more thrombogenic. And these are reflected, I think we have some way to get it back. Okay, and these are evidenced by signs or stigmata of endothelial cell activation, like increase in pre-selectin, change in the microparticles, which I'll talk a little bit later, and some other issues there. Now we have to come to the third of his triad, and these are abnormal contents in the blood, and they would include those in the plasma with the abnormal immunoglobulins, like in plasma cell dyscrasias, increase in various blood clotting factors, and there is also increase in the adhesive molecules and microparticles, and also the 2 inhibitors of the fibrinolytic activity, that is the Pi1, plasminogen activated type 1 and type 2. And some patients that may have also comorbid thrombophilia, like the hereditary ones, and antiphospholipid syndrome. The other part of the abnormal blood contents, that's a third of the triad, are those in the tumor cells, because the tumor cells themselves express tissue factor, which is up in the top of the hierarchy of coagulation. cancer procoagulant, and some other clauses, and also inhibitors of fibrinolysis, Pi1 and Pi2. And more importantly, when there's apoptosis, whether the apoptosis is spontaneous apoptosis or that induced by chemotherapy or by radiation, the apoptosis activates the tissue factor, which leads to coagulation, activation, thrombin generation, fibrin formation, and therefore to thrombosis. So I would now turn to acute promyelocytic leukemia. Okay, the first one is the tissue factor. This is a procoagulant, as I said, is the very top of the hierarchy of where coagulation cascade is started. Normally it's encrypted, it's not active, but it's activated during chemotherapy because the process of apoptosis will release phosphatidylserine, which activates the tissue factor and the active tissue factor. Now, in the case of APL, the APL promyelocytes has high expression of tissue factor, as high as up to 300 times that of the healthy patients or healthy individuals. And so particularly when there is inflammatory cytokines or tumor-derived cytokines, the expression is even higher. The APL promyelocytes also express cancer procoagulant and the inhibitors of fibrinolysis. We have been interested for some time on the microparticles. What are microparticles? They are cell fragments measuring 0.03 to 0.1 micron in the circulating plasma. And in APL, we found that they express high quantities of active tissue factor, high quantity of Pi1, which is inhibitor of fibrinolysis, as well as annexin 2 and TPA. These two are fibrinolytic activators. And they are derived from the APL promyelocytes, the leukemic cells, as well as from endothelium platelets or monocytes. And again, when there's inflammatory cytokines present, we see a higher content of the tissue factor. So to recapitulate quickly, in APL, the promyelocytes express tissue factor, which activates the coagulation cascade, which leads to DIC on one hand and to bleeding and to thrombosis on the other hand. When there's apoptosis, the apoptosis, as I mentioned, activate the tissue factor, so it leads to the coagulation activation. If there's presence of infection, the inflammatory cytokines will also increase the inhibitor of fibrinolysis and therefore increase the risk of thrombosis. And when ATRA is used, we found that ATRA by itself will increase the rate of thrombosis, but it's made worse when there's a differentiation syndrome or retinoid syndrome, which is seen not only with ATRA, but we're seen with arsenic treatment. When it is associated with leukocytosis, the thrombotic risk is increased. So with that, on the other side of the coin, the promyelocytes also increase expression of both TPA and of UPA and of annexin A2. Annexin A2 is a receptor for plasminogen as well for of TPA, and that will increase the fibrinolysis and lead to the bleeding. And finally, obviously, if there's a severe thrombocytopenia, it adds to bleeding as well. So a word of management here. We know that the coagulopathy that I mentioned will resolve 5 to 7 days after either ATRA or arsenic is started. But when during the induction therapy, during the first month of that, marked as early death, it is because of the coagulopathy. There's a little change in the rate of early death over time. In other words, pre-ATRA or post-ATRA era. So in the meantime, heparin is not effective for the coagulopathy, and antifibrinolytic agent like epsilon aminocaproyas or Amica or tranexamic acid, they're not able to prevent the intracranial hemorrhage. So what is missing here, I want to mention that the major cause of death for the early deaths is due to bleeding. And it's up to 30% during the therapy. And among the bleeders, 80% of the bleeding is intracranial. And I want to mention that because that's how I emphasize that intracranial hemorrhage is really a very high risk in these patients. And one of the reasons for that is that in the microcirculation in the brain, the annexin 2 is constitutionally highly expressed, even in healthy individuals. So we believe that is the reason for the high rate of intracranial hemorrhage. So the current recommendation is that as soon as feasible, ATRA should be given. In our institution, we will start the patient on ATRA the minute we know this patient has acute leukemia, particularly when it's associated with coagulopathy. The second thing is that we should provide very aggressive blood product support, cryoprecipitate for the low fibrinogen level, FFP, and platelets, obviously. And don't forget the high risk group are those with high white count, those with thrombocytopenia, and low fibrinogen. I think this is running faster than I could catch up with it. Okay. One notable thing is that a number of our colleagues had found out that even in academic institutions, sometimes ATRA is not started right away. And the data has shown that, just recently presented at ASH, that if it started more than 1 day after presentation, the mortality rate is higher. So this is, I just want to emphasize this aspect. Now we have to turn to multiple myeloma. The pathogenesis of that is as follows. In the myeloma cells, as well as the bone marrow stroma cells in myeloma, there's an increased expression of various clotting factors like von Willebrand factor, factor 8, 7, 9, and fibrinogen. These clotting factors therefore provide a greater potential for the generation of thrombin. In addition to that, these cells express these cytokines, which I call the tumor-derived cytokines, IL-6, TNF-alpha, and VEGF. And all these will stimulate the expression of tissue factor in endothelial cells and in monocytes and in platelets. And that leads to coagulation and risk of fibrinolysis. And risk of thrombosis. Now, the ultimate results, the incidence of thrombosis, depends very much on the therapeutic agent used. Take thalidomide. Thalidomide increases these cytokines. Thalidomide, also one of the main pharmacologic action, is increasing the apoptosis. Come on. Is to increase apoptosis. And, And that leads to activating the tissue factor, which I mentioned before. With high-dose dexamethasone, there's increase of adhesion molecules, and there's increase of PI1, which is inhibitor of fibrinolysis, and that leads to increased rate of thrombosis. With anthracycline, obviously it causes apoptosis, activates tissue factor activation, and then it also by itself will increase the tissue factor expression on monocytes and decrease the natural anticoagulant, which is protein C. And with that, there's increase in rate of thrombosis. On the other hand, using another therapeutic agent, bortezomib, one of the actions is that the platelet aggregation is decreased, so it decreased the risk of thrombosis. At the same time, there's overexpression of two transcriptional factor, the KLF2 and KLF4, which leads to suppression on NF-kappa B, which is the one that controls the expression of PI1. So it decreased the PI1, and therefore decreased the risk of thrombosis. At the same time, bortezomib also increased thrombomodulin in the endothelial cells, and thrombomodulin is the one that stimulates protein C activation, and that would counteract the other thrombotic risk. So this concept is borne out by actual observation of the incidence of thrombosis with different forms of therapy. This is published a couple of years ago, show that with thalidomide alone, the rate is 4%. You add high-dose dexamethasone, increase to 17%. You add an alkylating agent, it's 20%. You add on anthracycline, 26%. In some other series, with all the combinations added, as you know, there are multiple regimens, the incidence can be as high as 40%. It's very interesting that another IMiD, lenalidomide, is less than 1%. I put 0%, but it's actually at a few percent. So, and even with high-dose DEX, it's only 15%, but low-dose DEX, the incidence is very low. So with that background, the recommendation for thromboprophylaxis in multiple myeloma is shown here. This is recently published, just about 2-3 months ago, that the incidence using low molecular heparin is about half, as shown in here. This is with thalidomide alone, thalidomide high dex. And the incidence, and also with warfarin, also is roughly halved. The couple of years back, there's a recommendation for the International Working Group for low risk is 81 milligrams aspirin a day, but for high risk, it should be full therapeutic dose of either heparin or warfarin. Now, time is running short. I have to move on to the second example, which is lymphoma. The incidence of thrombosis in lymphoma as a whole depends obviously on the type of lymphoma, the histologic grade, and also the tumor burden. The highest is the primary CNS lymphoma, is close to 60%. With Hodgkin's, is 8.1%, and it's much lower with 1.5%. I'd just like to get a word in for microparticles study that we had carried out recently, and for the sake of time, just concentrate on the last group. This is at the time of diagnosis, the tissue factor that is present in the microparticles derived from platelets. This is after treatment. The yellow bar is the healthy control. And finally, for myeloproliferative neoplasms, we had a change of our thinking as to the thrombotic complications there. In the very large series, in the ACLAP study done in Europe, it was found that these two are major decisive factors: age over 60 and past history. And it is at the time of the thrombotic complications, there's no correlation with the hematocrit or with the platelet count. However, white count more than 15,000 also has a higher risk. What about the Jektu mutation? The risk correlates with whether or not the patient has Jektu or the allele burden of the Jektu V617 mutation. And obviously, if there's presence of inflammatory cytokines, it goes with the rest of it. It increases the risk. And obviously, we also study microparticles in myeloproliferative neoplasms, and we found that, again, they have increase in expression of tissue factor. So you can see this is the tissue factor. The red bar are patients, and the yellow, the healthy control. You can see it's higher in microparticles with tissue factor. And the last two columns here is tissue factor-bearing microparticles in CD14 fragments, which are monocytes-derived or platelet-derived. So, let's see. In summary, the incidence of venous thrombosis as well as arterial thrombosis, but more well documented with the venal, it's higher in hematologic malignancies than in most solid tumors. In APL, there's a risk of both thrombosis and bleeding. In myeloma, the major determinant of the risk of thrombosis is the choice of the drug we use. In myeloproliferative neoplasm, as well as in the other disorders, tissue factor is increased. that in the microparticles. So finally, with close to the end of my talk, I'd like to acknowledge my colleague, Martin Tallman, and the other members. Thank you.